This conference will now be recorded.
All right. Well, thank you for joining us, and good morning. We're here to introduce you to the Lurie Children's team from the Division of Orthopedic Surgery and Sports Medicine. For this session, we are introducing you to our advanced practice nurse, JackieTurner, and she'll be discussing concussions today. But before we get to Jackie, I would like to talk to you about our Division of Orthopedic Surgery and Sports Medicine. We are a nationally ranked by U.S. News and World Report. We care for more than 30,000 children each year. We provide a range of services for children with bone, joint, muscle, ligament, tendon, and nerve disorders. And we offer the only pediatric bone health program in Illinois. This is how we are able to recruit fine specialists in the nation. The Knee Injury Prevention Program, also known as KIP, sorry folks, so I didn't change the slides. Our Knee Injury Prevention Program, known as KIP, is a neuromuscular training program designed to reduce the risk of ACL injuries among female adolescent athletes. KIP for Coaches is a free online training program to help coaches reduce the risk of ACL tears and other lower extremity injuries in their athletes from the ages 10 to 21. In KIP training, coaches learn to lead their athletes through a 10-minute warm-up routine that includes strength training exercises, plyometrics, balance training, agility drills, and active stretching. Our clubfoot program is a comprehensive and multidisciplinary program for clubfoot, a congenital condition that can affect one or both feet in newborns. The concussion program is uniquely qualified to evaluate, manage, and treat concussions in children and adolescents. I would like to remind you that our new Skokie site is up and running. We have over 20 specialties, including orthopedic surgery, sports medicine, and cast care services. Our sports medicine team is there 5 days a week, one of which is JackieTurner. Jackie is the lead provider in the concussion program. She is an advanced practice nurse in the Department of Orthopedic Surgery and Sports Medicine here at Lurie Children's. Jackie specializes in concussion management. She received her bachelor's degree in nursing from Marquette University and a master's in nursing from North Park University. I'd like to encourage you to ask questions in our chat room today. We will be answering them after Jackie discusses has her discussion about concussions. But without further ado, Jackie, why don't you go ahead and take it away? I'll give you the screen and go ahead and take over.
Okay, are you able to see it?
We sure are.
Okay. So I'm going to be talking today, just a brief talk about concussion management in the pediatric population. So first talking about what is a concussion. So it is a traumatic brain injury, categorized under that, induced by biomechanical forces. So it is a subset of what we call mild TBI. There's some 5 common features. So there is some kind of direct, often indirect blow to the head, such as with a whiplash injury, that transmit that force to the head and to the brain. There's usually a rapid onset of some neurologic function that does resolve spontaneously. It may develop over minutes and hours and progress after the injury. It's important to note that those signs and symptoms, they're from a functional disturbance. So there's not any kind of structural injury, no changes on any standard neuroimaging, CT scan, MRI, X-ray, and a lot of patients I find don't really understand that. So that's what I start when I start explaining concussion to them. That's usually where I start. There's a range of signs and symptoms. It doesn't always include loss of consciousness. There's actually only about 10% of concussions have loss of consciousness at the time of injury. The resolution can typically follow a sequential course. However, in some cases, the symptoms can be prolonged, which is the majority of patients that I see. And again, those symptoms cannot be explained by something else. So not some structural injury or maybe some mental health issue they're having right then. If it's more of a migraine, it can't be explained by anything else. So looking at the epidemiology, between 1 and 2 million reported concussions per year in kids less than 18. Probably not surprising to anyone, in the last 10 years, the ED visits have increased over 200%. They are about 2 times higher in girls sports than in boys sports. So if you compare girls basketball, boys basketball, the rates are about 2 times higher in girls basketball. Fortunately, and hopefully with a lot of the education that we've done over the last few years, the repeat concussion rates have been down in the past 4 years. When you're looking at contact sports, the rates of the overall injury, including concussion, increase with age, increase with pubertal maturation status. So if there's just bigger bodies, more force, they're stronger, there's just going to be more injuries, including concussion. But actually more than 50% of concussions are not related to organized sports. And we've seen that a lot in the last year. There hasn't been a lot of organized sports. So recently sledding, skiing, before that it was a lot of scooters, bikes, skateboards. So when you're looking at symptoms, they can be broken down in a few different areas. You have your somatic symptoms. So headache is very, very common. Sometimes some nausea, not as often vomiting. Pain in the neck, especially if there was more of a whiplash type injury, a motor vehicle accident. Usually some light noise sensitivity acutely that tends to get better in the first few days, weeks after the injury. A lot of vestibular and ocular motor symptoms, some dizziness, less often hearing problems or tinnitus, but it does happen, balance problems, all related to that vestibular system. Lots of cognitive issues, and a lot of our kids notice that just because they have such high cognitive demands throughout their day with school. So a lot of difficulty concentrating, reporting feeling confused or foggy, trouble with memory. So whether that's remembering their test questions or conveniently not remembering what their parents have told them to do. Sometimes they feel like they just answer questions slowly. It's hard finding the right word. They're tripping over words, repeating the questions. But again, there's usually not a lot of patients have loss of consciousness at the time of injury. Lots of emotional symptoms, and I hear a lot of the same things of irritable, more emotional, sad, sometimes happy out of nowhere. A lot of them will tell me that a kind of situation that would bother them, it bothers them a lot more. They overreact a lot more than they would to that situation, and then it takes them a lot longer to come down from that situation too, and they really can't understand why. But that's a typical story that I hear. And then a lot of sleep problems, especially lately now that kids are mostly in their home, in their room, and not able to get out, not get into routine and get out their energy. So sometimes feeling just very tired throughout the day, feeling slowed down, but a lot of trouble falling asleep, staying asleep, sleep patterns are off, and then just feeling very tired throughout the morning, not getting any restful, restorative sleep. So my evaluation starts with a lot of history taking. So really looking at what was the mechanism of injury, how were they hit, the force, what symptoms did they have at the time of injury? Because some studies have found that if they're dizzy right then, that could add on, that could possibly predispose them to having a longer recovery. The severity of symptoms at the time of injury does not correlate with the time of recovery. They can lose consciousness, potentially have a seizure, be very out of it, and appear to have a severe injury, but that really doesn't have any effect on what their recovery time is. Looking at their past medical history, so if they had any previous head injuries, and really delving into how long did that take to get better, what were their issues, what was their treatment like, and then did they have any migraines before this, learning disabilities or difficulty with school, any neurological or psychological disorders, and then looking at the family history of that too. The physical exam, doing a head-to-toe exam, including the neurologic exam, so looking at their head and neck, range of motion, cervical tenderness, looking at their vestibular, so Romberg tandem gait, but also you could see to the side this BESS, this balance error scoring system that takes 2 minutes to complete, and it gives them a score on all 6 of these different measures on the floor and then on the foam pad, just to give us an idea of where they're at balance-wise. We do have our own normative data. There's not really any established, but it's really helpful to follow this score for this person throughout their recovery. And then looking a lot at visual symptoms. So tracking, convergence, saccades, smooth pursuit, quick eye movements. Typically the physical exam, especially the neurologic exam, is normal in concussion, but it's that visual tracking, sometimes the eye movements that we could see, they don't track smoothly, their eyes might be all over the place, they have difficulty following my finger, or then asking for subjectively how they feel through all of those movements. Are they getting dizzy or nauseous or eyes tired, feel like they have trouble with that? And then doing some combination of a mini mental status exam. It's really hard with the younger kids, but at least just getting that baseline kind of where they're at. Evaluation, so typically my evaluation, especially I see the patients not usually in that acute period, 2 to 3 days after injury, but in that period following the APRN criteria is important to decide whether or not you want to get any imaging. You can find this. If I do order any imaging, it's usually an MRI without contrast of the brain, and those are for patients if you maybe, the story's a little unclear if they did have a head injury or concussion or not, that you want to make sure there's no structural injury. Anyone who's having like progressively worsening headaches, worst headache of their life, really tired, lethargic, cannot be woken up, or really difficult to wake up, weakness on one side of their body, slurred speech, any of those neurologic symptoms that would be a red flag and maybe warrant some imaging. Sometimes we do, if they've just had symptoms for so long, parents sometimes want that reassurance. They're so nervous that there is something other than a concussion. So we'll talk about that with them, the risk versus benefits of doing that. When we talk about diagnosis, we really, at the time of injury, don't classify them as mild, moderate, severe anymore, simple versus complex. Again, it's really not helpful in their prognosis or the management. Instead, we sometimes say like they'll have a typical recovery within that 4 weeks of injury, or maybe a prolonged recovery, some persistent symptoms that's longer than that usual 4-week recovery period in a pediatric patient. But we can't even really say that until they are fully recovered. So my management, I really try and take an individualized approach with every patient. So looking at their mechanism of injury, their concussion history, their medical history, and doing a lot of education about what is a concussion, and then what are their expectations for recovery? What does their prognosis look like? As best as you can. There's no way that we can predict when you see someone how long it's going to take to get better, but setting up some expectations for them and giving them some realistic expectations. Also assessing for any deficits that may require rehabilitation, so physical therapy, sometimes an optometrist eye therapy, if they need psychological counseling, sleep medicine, neuropsychology, really looking at what that patient needs. And then a lot of it is guiding back to school and giving them some guidance on returning to physical activity. So not necessarily that standardized return to play, but even what they can do exercise, physical activity wise throughout their recovery. I cannot emphasize this enough. We really try and not eliminate all of what they do throughout the day, the cognitive, the physical activities. We just want to reduce them to a level that doesn't increase their symptoms. Kind of gone are those days of resting in a quiet, dark room until you feel better. If they need to be somewhere quiet and that's where they feel the best for a day or two after the injury, that's okay. But after that, we really want to get them back to normal life, even if it's a class period, doing a 5-minute assignment, getting out of their room, getting out of the house, and really getting them used to that normal daily activities again. We find that strict physical rest can actually take longer to recover, and they actually might report higher symptoms if they haven't been doing anything. And then strict cognitive rest had similar recovery times to those that only had mild reduction in workloads. So again, not complete elimination of everything, just gradually getting back to their normal lives. Exercise is really important in those first few weeks after the injury. So after 1 or 2 days, actually encouraging them to get out and go for a walk if they can. We try and get up to 20 minutes of aerobic activity, and that could just be walking outside. Reasons they would stop sooner is if their overall symptoms that they rate themselves increase by 2 points if they rate themselves on a 10-point scale. We talk a lot about healthy lifestyle, so sleep hygiene, drinking plenty of water, eating a healthy diet, things that we always counsel kids on that they should be doing anyway, but are especially important during their concussion recovery. Everyone always asks about screen time. So we want to say limit if you're worsening symptoms. Television's usually better tolerated than video games. There's not a whole lot of decision making that goes into that. And again, we want to avoid that complete elimination because It could lead to some social isolation, depressive, anxious symptoms. So if they're not seeing their friends, not going to school, they can't have their phone, they can't have their tablet, they can't have TV, well, are they not sleeping and crabby and having headaches and stomach aches and physical symptoms from the concussion, or because of how we've changed their entire life? There's not a lot of evidence to support the use of any kind of medications in concussion pediatric patients. If they do want to take over-the-counter pain medication, Tylenol, Motrin, Aleve, we really try and limit it to no more than 2 times a week just to avoid overuse headaches. Return to learn, we want to get them back into school within about 48 hours. There should be a return to learn team in each of their schools now that can help them with all these different accommodations. So again, it's a really individualized approach of what age they're at and what their class load looks like, but we always give them a letter for school with some accommodations to get them back and get them comfortable and get them with an appropriate workload. What I found with virtual learning this past year, there has been some benefits. They're outside of that busy classroom environment. A lot of times they can go at their own pace. They're not singled out, they're not different. Everybody's at home, no one really knows what you're doing, which is important to kids. Some disadvantages, there's really not a whole lot of face-to-face time with teachers. Sometimes it's hard to ask for help. And unfortunately, there's a lot of screen time, which if kids are bothered by screens, that can just make the symptoms worse. When talking about return to play, it's really important that you educate them that no athlete should be allowed to return to play the same day if there's any concern of concussion. They need to sit out the rest of the day. Because if they continue to play, they are more likely to have worse symptoms and take longer to get better. This is the standardized return to play protocol, whether it's youth, professional, college. This is the most updated return to play protocol. But again, it's very individualized and kind of seeing where the patient's at in their recovery and what they can tolerate to get back to. You hear a lot about post-concussion syndrome. It's no longer included in the DSM-5. There's really no consensus on the time frame, the definition. So we try to avoid that as a syndrome and kind of what that conveys to patients of what they have, and more call it that, we're starting more to call it the persistent post-concussive symptoms that they're having. So what if they aren't better in 4 weeks? This is where we're evaluating if they need to be referred to all these services that we have at Lurie and within our team to help with the different areas. Sometimes it's all of these areas, but sometimes just one, just to really benefit them and get them better faster. We get this a lot. So how many concussions are too many? When is it important? Is it time to consider retiring from contact sports? There's not a lot of evidence out there, even for professional athletes. A lot of it gives some suggestions, but then says refer to a sports medicine specialist to further discuss. Sometimes with kids, again, because they're not at that super elite level, but we'll talk about maybe a prolonged period away from sports. So if they've had 3 concussions in a single season, so in that 3 to 4 month period, if they're having persistent symptoms, so lasting longer than 3 months, if each concussion is getting worse and worse symptoms, or there is less and less force causing these concussions, we'll just have that discussion with the family of what their risks, benefits of continuing in that sport or that activity is. And again, if you're uncomfortable making a determination, referring to a sports medicine specialist who has this expertise is really helpful to the families. And I believe that is it.
That was great, Jackie. Just absolutely great. You know.
Thank you. Do you want me to exit out?
No, we're fine. I'll override you, so it'll be fine.
Okay.
So, you know, I gotta tell you, it's just with concussions coming to the forefront over the last, let's say 5 years. Back when I played sports, it was getting your bell rung. So it's so important to understand that concussions are a very serious matter. And now, we have questions now are saying, like, when do you recommend a pediatrician refer a concussion patient to you?
So definitely, and this is where we excel and where our expertise is, so most kids get better in about 4 weeks. The CDC even says like 1 to 3 months could be a typical recovery period, but probably around that 3 to 4 week mark if they really don't seem like they're making much progress. that's where we can step in and see, are there other specialists and people on our team that we need to refer them to? So whether that's getting them connected with physical therapy, our eye specialist, neuropsychology, psychology, sleep medicine, neurology, we can better evaluate that and then come up with a school plan too and really work with them, which is we have so much experience with that of even communicating with their school, whether it's a letter or a discussion on the phone. But we would be happy to see patients at any point. Sometimes our schedules don't allow us to have that acute evaluation of them. So if there's a head injury and they need to be evaluated within a day or two of the injury, depending on how severe their symptoms are, usually a pediatrician's office, urgent care, ED, is best just to get that neurologic exam, make sure that it is a concussion, that there's not concern for a structural injury or a reason to get a scan. We'd be happy to see patients more in that acute period too, within the first 1 to 2 weeks. That can actually be beneficial. We can get them out of bed, exercising, which can actually have positive effects and shorten their recovery. We're also happy to see patients who maybe aren't experiencing concussion symptoms now, but they've had 1, 2, 3 in the past, and they or the pediatrician is just concerned about the number of concussions they've had or and what sport they're going back to. And we have a lot of those conversations too with patients, maybe even doing baseline testing, counseling them on what to do if there's another head injury, or what are those risks benefits of participating in that sport with their concussion and their medical history.
Okay. So one question that popped up was, what's the difference between referring to sports med or neurology?
So at Lurie, if the diagnosis is concussion and you put in a referral, even to neurology, our scheduling team knows to route them to us, to sports medicine. Our neurologists prefer that we evaluate them and do their intake. If there is a concern for other neurological issue, if their headaches are the main reason and we want them to get evaluated for headaches, our neurologists are more than happy to see them. But a lot of their management, the referral to the specialist, their return to school, the decision on returning to play and clearing them, they prefer we manage that.
Okay. So we're talking about referral into Lurie for sports medicine team, and we're let's just say our pediatrician has a concern of concussion. Which one of our locations are we able to see concussion patients? I know we had talked earlier about our new Skokie clinic, and we can see folks in Skokie. Where else are we seeing concussion patients here at Lurie?
Northbrook, Skokie, there is not as much availability, but sometimes at the Clark Street location, Lurie downtown, occasionally Westchester and New Lenox, but the majority of our program is up at Northbrook or in the city. Northbrook, Skokie, great. In the city, sorry.
All right, excellent. Thank you for that. We are really blessed to have a lot of physical therapists on the call with us today. And I'd like to thank you all for joining us. One of the physical therapists, Deanna, has put in the chat room, from a physical therapy perspective, is there any sort of rehab training protocol that you prefer your clients follow? For example, Deanna's had some physicians request that she perform the Buffalo concussion treadmill test to progress towards returning to sport. Can you comment on that?
Yeah, so that is the standard, some type of the Buffalo concussion treadmill test. And that's when I talked about the exercise advice that I give patients who haven't been connected with a physical therapist, of trying to exercise that 20 minutes and stopping if their symptoms increase by more than 2 is part of that protocol, but they're able to just do it at home. But yeah, so usually I recommend some kind of vestibular evaluation. So looking at both balance and eye movements. And then also I usually include in my order looking at the cervical muscles, because again, there could be a whiplash type injury. There's usually a lot of tightness, terrible posture with kids, and that can actually be contributing to headaches too. So between the cervical spine, the vestibular, and the subsymptom threshold exercise training or Buffalo concussion treadmill test, those are the 3 things I request physical therapists to address.
Okay. And then Melissa has a question similar to Julie. Is there someone on your team that you would consider to be the gatekeeper? Is that you, or is that,
Yeah, I think that would be me. It's a little bit of case managing that I say I would do, of getting patients connected with the different therapies and services that they might and specialists they might need, but then always coming back to me for the school accommodations, maybe like further discussing the lifestyle recommendations, what they should be doing every day, and then ultimately it's up to me to clear them to return to sports. So yeah, I would consider myself that.
Okay. Paula Nowak, who's one of our physician
Hmm.
liaisons like me and Julie, um, our team, we're confronted with this question a lot, and it has to do with access. And so with that in mind, how long is the wait time to get into your clinic? Do you do telemedicine appointments? Can you kind of like
Yeah.
help us with that?
So our goal is usually within 2 weeks of the appointment request. Concussions, there haven't been sports lately, and so there haven't been a lot of concussions. So recently we've been able to get patients within a week. Um, and yes, we do have telemedicine appointments now that we've started for the last year. I like to see new patients for the first time in person just to do a good physical exam and see them and test their balance. That is ideal. But if they've been seen and evaluated at their pediatrician's office or an urgent care, and I know someone has eyes on them, we could always do a telemedicine visit too if we need to get them in. There's definitely more availability able to do telemedicine than like the physical clinic space is what I'm at the mercy of. So yeah, our goal is within a week or two to get the patients in.
Well, that's great. That's really great to know. As you mentioned, kids are getting back into sports again. I for one, I coach basketball and baseball, and my daughter's basketball team just started. Do you have advice for the pediatricians and the coaches and everyone else out there, for everyone getting back, all these kids getting back into sports,
Yeah.
whether concussion related or not, from
Hmm.
a sports medicine standpoint? Can you provide some of the pediatricians and physical therapists out there to provide advice to getting started back in the sports?
Right. So we are worried about that kids have been inactive for so long that they're very deconditioned, out of shape, not used to being active. So we're prepared to get see a lot more patients soon, whether that's acute injuries or overuse injuries. The best thing is just kind of taking it slow and doing that conditioning, um, doing something like a KIT program and strengthening and endurance training prior to jumping right back into everything. From a concussion standpoint, again, that just goes with injuries. There's just most likely going to be more injuries with kids not being in shape, but there's really no equipment or anything that helps prevent concussions. Helmets, headbands,
Right.
mouth guards don't prevent concussions, but it's just that education is if they do suspect that they have a concussion, they got a hit to their head or their body, that they remove themselves from play right away is really important, and not it for the rest of the day. So whether it's gym class or a practice or a game, that they stop and they rest for the rest of that day until they see how the symptoms progress or get evaluated. That's the best thing that I could recommend.
Excellent. Well, thank you for that. One of the things I wanted to mention to everybody who's on the line right now and who will be listening to this recording later is that we do have an immediate care center both in Northbrook and into our Lincoln Park locations. And those are after hour clinics when your pediatrician is not available. So we're here to help supplement your pediatrician when their office is closed on the weekends. And we know a lot of sports are played now on the weekends. So, and the benefit of having sending one of your children to our immediate care is they have a direct insight into our sports medicine team. So I just like to throw that out to you all there. But I don't see any other questions in the chat room. Um, so we're going to go ahead and get ready to end our call here. But again, I want to remind you about our Skokie location. It's brand new, and we have the sports medicine doctors there 5 days a week. Again, I want to also mention the immediate care one more time to you. If anybody has any questions regarding our immediate care or Skokie locations, please reach out to me. I will be sending this recording out to all of you who are attending, along with some of the slides and some of our marketing collateral to learn more about our sports medicine team. But to get a hold of Jackie, you can call her at 312-227-6190, or feel free to email her at JaCturner@LurieChildrens.org. Or for those of you who are able to, use Rapid Connect or Epic in Basket for her. But on behalf of the Pediatric Orthopedic Medicine and Sports Medicine team, I'd like to thank you for joining us today. And I hope you could join us again for Dr. Carl. She will be talking about the pediatric knee at 12:30 today. Jackie, would you like to say anything before we sign off?
Just thank you, and feel free to reach out with any questions, whether it's about our program, a specific patient that you guys want some kind of counseling on or recommendations. I'd be more than happy to talk with you.
Well, that's great. Thank you so much for having us, for joining us today, Jackie, and everybody else for joining us. And we'll see you all soon.